Hello, everyone. Thank you for coming. Welcome to NAHDO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendees screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Thank you, Erica. Welcome, everyone, to Day 2 of NAHDO's 39th Annual Conference. We had a lot of participation yesterday, and I look forward to another great day today. But I do want to take just another minute to recognize and thank all of our sponsors for supporting us and for making this event possible. I would also like to give a special shout out to NAHDO Strategic Partners. Strategic Partners are NAHDO members that have also engaged with us as event sponsors. We truly appreciate their support and the opportunity to work closely with them. I want to cover just a few of the pro tips that I mentioned yesterday to help you experience the full impact of the conference. By now, you should be familiar with both the conference program and the agenda features. This is the primary way that you can find sessions of interest and participate. Of course, I can see that many of you have found the token hunt game. That's exciting. Just know that the prize drawing is based on the number of correct entries you make. The more, the better. But even if you have just a few, you still have a chance of winning. This morning, we had the virtual coffee shops were open, and in a little while, we're going to have some Meet the Expert or deep dive networking rooms open. We hope you'll stop by. For those that haven't tried yet, now would be a good time to find people and connect with them using the attendee list. Of course, just a little friendly reminder about our in-person meetings. We hope that you'll plan now to join us in Austin, Texas, May 6th through 8th, 2025. And since this event will again be capacity controlled, you'll want to pre-register now to reserve your spot. It is now my privilege to announce the recipients of the NAHDO Innovation and Data Dissemination Awards. These awards were presented at our in-person meeting in New Orleans to the Washington Office of Insurance Commissioner and the Nevada Department of Health and Human Services. You can read their full citations on our website at nahdo.org/awards. We will now hear just a few words from both of them.
My name is Simon Casson. I am a senior and data economic analyst at the Office of the Insurance Commissioner, and really like to express my gratitude to being recognized by NAHDO for our mental health dashboard work. Also would like to thank Onpoint Health Data, who we worked with closely to produce these dashboards. These dashboards are a really great way of showing mental health trend data over time, and they really are designed to be read by a wide audience, so anyone from a legislator to the general public to a subject matter expert. Also say that I've really enjoyed participating in all NAHDO events. I've learned a lot from our health data peers across the country. So thank you for doing what you do, and thank you so much for honoring us with this award.
Hi there, I am Jane Beyer, and I am the Senior Health Policy Advisor here at the Washington State Office of the Insurance Commissioner. And the first thing I want to do is express my thanks and OIC's thanks to NAHDO for this lovely award, which we absolutely could not have done without the great work by Onpoint. Onpoint reviewed probably hundreds of thousands of claims that relate to the use of mental health services in commercial health plans in Washington State, and remarkably turned all of that complex information into a data dashboard that's posted on our website that is incredibly simple to use and tells a really thorough story about who's accessing healthcare, how much it costs, what the trends have been over time in use of those services, and how use varies from one part of the state to the other. And we clearly could not have done this without the great work from Onpoint.
Kyra Morgan here with the Nevada Department of Health and Human Services. I am really excited and honored to accept the Innovation in Data Dissemination Award on behalf of Nevada and our Office of Analytics. They've done a great deal of work to improve data transparency for Nevada. And when they were created just a couple years ago, one major goal was really to be able to disseminate data across a wide array of topics in a consistent and easy to use format, and ideally all available through a single location. And that's what they've done through the data portal. So the data that are available range from behavioral health to substance use to maternal and child health, including not just your standard birth certificate information, but also specific areas like child protective services and child care access and WIC participation, as well as Medicaid enrollment and utilization. We have a dashboard for population demographics, some information from our statewide surveys like the Behavioral Risk Factor Surveillance System, mortality and leading cause of death data, as well as chronic and infectious diseases. And as you all know, actually, the expectation around data transparency gained so much momentum during the COVID-19 pandemic that was actually an integral piece to us being able to stand up such a robust suite of data, because from a stakeholder perspective, if you can do it for COVID, why can't you do it for all these other topics? So one of our most popular dashboards that I wanted to mention is our community health profiles. It allows legislators and other stakeholders, anyone really, to query a dashboard by legislative district, so assembly, state, and congressional district, as well as by county or statewide. And in addition to having those kind of regional specific views, there's also a ranking that allows our legislators to look at their specific region compared to their neighbors. And that's gained a lot of popularity. So I would say go check it out if you have a minute. But generally speaking, I just want to thank NAHDO for the recognition.
Well, congratulations to both Washington and Nevada for those fabulous dashboards that they have created to help disseminate data. We're now going to go right into our daily opening plenary session, Value and Analytics, Healthcare Costs. This session has been organized and will be moderated by Kevin McAvey from Manat. This session is sponsored by Milliman Med Insight, one of NAHDO's strategic partners, and we want to thank Milliman Med Insight for their support and for their continued engagement with NAHDO on key issues, especially related to analytics. With that, I'm going to ask Charles to bring Kevin on stage, and we will turn it over to him. Hey, Kevin, it's all yours.
Hello, hello. Can you hear me okay? Terrific, terrific. Well, it's my personal pleasure to be here. For those I haven't met, my name is Kevin McAvey. I am a managing director at Manat Health. I've been with Manat now for 8 years. Prior to that, I was doing federal work, and then I had the pleasure and privilege to work at the Center for Health Information and Analysis in Massachusetts for its first 4 years. And those are some of the most proudest years of my life and my career so far. And I am so thankful for all of the work that they do and so much of the work that state health data organizations across the country, like many of you, are doing every single day. State health data organizations are state designated agencies or entities that derive information from a diverse array of healthcare system data to inform policymaking and regulatory decision making. And they are critical for understanding of healthcare system performance, including the value we derive from our healthcare system, the costs we pay, who pays them, for what services, and to what end. What quality of services do we receive? What are the eventual outcomes of those interventions and services delivered? Today, it's my personal pleasure, as I work in the health data world with so many of you every single day, to bring on stage 3 of our colleagues who are doing particularly innovative work across the country, developing actionable insights for policymakers and regulators and ultimately the public to better understand how our healthcare system is delivering value for us. In our first presentation today, We will hear from Phil Morris, a research scientist with the Cost and Quality Analysis Group at the California Department of Healthcare Access and Information, HCAI, his primary role is to learn about a variety of data resources and apply those to building diverse data reports and visualizations. He's been with HCAI, formerly OSHPD, for about 10 years. And prior to that, he spent 5 years as an informatics specialist with the California office of AIDS. He is a tremendous technical subject matter expert in our field, and he'll be speaking to the lessons learned and future opportunities from analyzing retail pharmacy claims in the state of California. So Charles, I'll pass it to you to bring Phil up on the stage.
Welcome to Lessons Learned and Future Opportunities from Analyzing Retail Pharmacy Claims. I'm your host, Phil Morris. First, we'll be looking at a current dashboard from the Healthcare Payments Data, HPD for short, which is California's all payers claims database. And this particular dashboard is fee-for-service drug costs in the commercial market. This dashboard was published at the end of July, and it allows users to explore the retail pharmacy claims for commercial plans in California in 2021. And it has 3 major topics: the top 25 costliest drugs, the top 25 most frequently prescribed drugs, and the top 25 drugs with the largest monthly median out-of-pocket cost. So next we'll look at some key findings. The top 25 costliest drugs in 2021 accounted for about 3% of all prescriptions, but accounted for 30% of the total cost, which was about $4 billion. The 4 most frequently prescribed drugs were all COVID-19 vaccines, and they all had no out-of-pocket costs. In addition, the top 25 most frequently prescribed drugs amounted for about 12% of all prescriptions and about 2% of the total cost. In addition, the monthly median out-of-pocket cost for the top 25 with the highest monthly median out-of-pocket cost ranged from $150 to $250, which highlights one of the state policies concerning the maximum out-of-pocket cost in the commercial market. This is a screenshot of the dashboard. As you can see at the top, there are 3 bars here that allow you to choose the topic area to focus on. You also have a filter here that allows you to focus on brand or generic. Then you have statewide totals and top 25 respective list totals, and then the actual 25 list down below. Each of these numbers have a tooltip associated with it, and the last tooltip for the monthly median out-of-pocket costs also includes a measure of distribution, the 25th percentile and the 75th percentile. Finally, there is a link to the visualization at the bottom of the page. Next, we'll discuss some of the caveats for this dashboard. For instance, this dashboard only includes retail pharmacy costs and does not include medical pharmacological costs. We did that because, honestly, retail pharmacy claims are easy to identify in the database. Pharmacy information in medical claims are a little bit more challenging. The level of analysis for this dashboard is National Drug Code, or NDC. That is why you will see the same drug name repeated on some of the top 25 lists, because each of those drug names have multiple NDCs that have made the list. An NDC is basically a combination of manufacturer information and product information, including strength of product, and also packaging information, including number of product units. Also, this dashboard only includes fee-for-service claims. That is because non-fee-for-service claims do not have a valid cost associated with them. And you'll notice by the chart below that Prior to 2022, Medi-Cal had many of their pharmacy claims listed as non-fee-for-service payment methods. And in California, a lot of times that is capitated. As you've probably guessed by now, this dashboard only includes commercial claims. We excluded Medi-Cal claims because of what we talked about in the previous slide in capitation, but we also excluded Medicare pharmacy claims because it had a data abnormality that indirectly caused issues with how we were reporting the pharmacy claims for Medicare. The costs in this dashboard do not include rebates, coupons, or other discounts. That is because HCAI does not currently collect those. But starting in 2026, we should be collecting them in our non-claims data. On these dashboards, there's a cost per prescription measurement, and it's simply the total cost divided by the number of prescriptions for each NDC. It's simple but imperfect. In the future, we would like to use either the 30-day supply or the number or quantity of pills to get a better measurement of cost per prescription. Before we start talking about some of the nuts and bolts and some of the decisions we made in data cleaning, let's review a few topics. First, the allowed amount is comprised of 5 parts, right? The payer paid amount, copay amount, deductible amount, coinsurance amount, and the member self-pay amount. The latter 4, from copay to member self-pay amount, are all used as a measurement of out-of-pocket cost for the members. So if you look at the next part, right, where we start talking about out-of-pocket cost, we take those 4, add them up, divide by 30-day supply, and we take the median by NDC of that number. As you may be aware of, the California's All Payers Claims database is fairly new. So there are times when it is difficult for researchers such as myself to determine if a data point reflects reality or is an error. So to mitigate that, we've done some data cleaning, including removing any claim with an allowed amount or quantity, number of pills, with a 0 or negative amounts. Also, we removed any claims that had any of the parts of the allowed amount, which are patient paid amount, copay amount, deductible amount, coinsurance amount, or member self-pay amount with negative amounts in them. Just as a further note, only primary unknown claims were used. Also, limited the effects of extreme values by using the median monthly out-of-pocket cost. We also removed any NDC that had less than 100 unique individuals. Remember, that would be less than 100 people receiving a prescription for that NDC in 2021 for the entire state of California. Next, we'll look at some of the changes for this upcoming version of the HPD drug cost dashboard. The people here at HCAI really appreciate being invited to present on this material, and we look forward to hearing your questions and like to thank you for your time.
Terrific. Phil, can you hear me? Really wonderful, grounded presentation. And California, I think as many in our really large audience today are aware, California has been a real leader in I think, collecting data on pharmaceutical costs for a long time and actually using that data to take action and intervene in a market where otherwise folks might not be able to afford things like insulin. Could you talk a little bit about where, like, what generated the interest in this particular project, and even where you're thinking it might head from here?
Right, I appreciate the question. Basically, it came about because we noticed that in our all payers claims database, that a lot of our data is capitated because that's how California is, but the drug or the prescription drugs are less so. So we were able to put something out that was easier to report because it was fee for service. So that's where we decided to start with, right? We traditionally look at our projects as a iterative process.
Yeah.
And so we'll do the walk, run, sprint approach.
Yeah.
And
Agile,
so
right? That's the right term.
Right. So,
well, that's terrific. And so as you were building it out, like what did you learn that others who are potentially and very likely exploring similar analyses should kind of take with them on their journey?
Right. So, right, as you can imagine, California is huge, and so this database,
40 million people.
Yeah. Well, yeah. Right. And so the prescription drug database is 3.5 or 4.5 billion claims. And so anytime I'm running anything, it takes a bit of time, as you can imagine. In addition, like some of the things we've noted, right, are the fact that, I was a little surprised by the fact that COVID vaccines was some of the most commonly prescribed, right, or commonly filled prescription.
Yeah.
So and it's a matter of, the database that large, you have trouble wrapping your mind around what is a small number, what's a large number, right? Mm-hmm. You're getting rid of 1 million records, but out of 1 billion, that's a small percentage. So it's that sort of thinking that you have to kind of adjust to.
Yeah, that's really helpful. And I'm gonna get really weedy with you for a second. For the programmers in the audience, and I know you're out there. How do you deal with long run times? Like what do you have any tips that you could share with working with a database this big that made your life easier?
I think one of the things that we've talked about and done locally is a little bit of chunking, right? Mm-hmm. Where you do, shave it off, right? Start with the large database and just kind of reduce as you go. Mm-hmm. And then maybe make each of the steps smaller so the run times are less.
Yep.
In addition, we're changing into a new model where hopefully we'll be using parallel processing. Mm-hmm. So that's going to speed up processing time in the future. Also, the other thing I tend to do is I'll put something to run and then I'll multitask and do something else in the meantime, like, read some articles or do whatever. So it's a matter of juggling your time.
And we have a question that's really helpful. We have a question from the audience, and then I want to ask a data limitations question, things we should know about the reporting. But a question from the audience, Sarah Crawford, do Medicaid and Medicare use any PBMs in California? And if so, how did you eliminate those specific PBM claims? Are those still included in the results here?
Yes, in this case, this is all retail. Mm-hmm. So theoretically, PBMs exist throughout the data. Admittedly, I don't think we really have a marker on that per se in the data that I'm aware of. Mm-hmm. So I might have to look into that a little bit more closely. Yeah. But I'm under the impression that basically all of these claims are from CVS or et cetera. So PBMs would be involved no matter what. This is more output, so to say.
Yeah, just to follow up on that one, like does HCAI and the HPD receive both the pharmaceutical claims within the payer submissions as well as separate submissions from PBM? And is there do you have to kind of determine which to use, or do they all come through the primary payer?
We do get both of them, and then our vendor, contractor Onpoint kind of puts them together and identifies them as duplicates, so to say, so that we're not double counting.
Terrific. Well, thank you, Onpoint. Jim, I think you're out there somewhere. So one last question for you, and this goes back to your point about this being a very kind of agile. We're starting with what we know, what data we have on hand, developing the code, developing the reports, making sure it's useful. But that said, I know that there are probably data limitations. There are gaps in the data that we have available, and there are also important reporting caveats. You started mentioning we don't have rebate data yet. Could you speak a little bit to kind of both the data gaps and the reporting limitations that we have at present, and what plans that you have in the future to address them?
Right, and some of them I identified earlier, but some of the limitations include the fact that right, like you said, we don't collect rebate information yet, but that's going to be part of our non-claims database that we'll be collecting, I believe, in 2026. And so that's going to be part of it that will get bigger picture, right? As you can imagine, also this database doesn't have things like wholesale acquisition costs or those sorts of things, which would further bolster. And we're working towards getting those together so we can understand more. The other limitations, go ahead.
No, please.
The other limitation is something that everyone knows about, I would think, or a lot of people do, is the fact that this isn't all the prescription drugs, right? Mm-hmm. There's also prescription drugs that are in the, the medical claims. And so that's part of it also, is it's not a full picture. It's only retail pharmacy.
Yeah.
So that's something else we're working towards.
Really helpful. And a bonus question from the audience for the dashboard. Are you thinking of expanding it by bringing in other payers in any way? Can you give us a hint for what's next?
Absolutely. Absolutely. We are definitely going to add in Medi-Cal and Medicare without a doubt next time. We might even be splitting that out by PPOs and HMOs and et cetera. Some subtypes maybe, but we're definitely expanding the two different ones. We're also expanding the brand and generic to add additional categories to that.
Terrific. Well, Phil, thank you for all that you do. The dashboards look terrific. Hopefully folks can visit them after this session. But thank you for all that you do and HCAI does. And maybe we'll see you at the end if we have a little bit of time for some additional questions.
Excellent. Thanks a lot. Appreciate your time.
So next we'll have, we'll go across the country from California to Vermont. And we'll hear from Hiroko Meserve, a senior health data analyst at Onpoint with experience in health data analysis based on claims data and major EMR systems, clinical data, particularly related to value-based care contracting with CMS and commercial health plans. Her current subjects at Onpoint include alternative payment models, non-claims-based payments, Medicare fee schedules, and personal healthcare expenditure analyses. She's a really talented analyst and a technical guru. We're really lucky to have her here today. And she's going to be joined by Annie Paumgarten, healthcare data statistical analyst at the Vermont Green Mountain Care Board. And Annie has extensive experience evaluating federal investments at the community and statewide level. Her past roles include leadership at a community-based mental health disability services agency serving high utilizers of the healthcare system, supporting analyses of the relationship between trauma and addiction relapse, and cost variation analyses. Again, another wonderfully talented analyst who's going to share some of her work and their work in Vermont. The title of their presentation, Bridging the Gap, Analyzing the Vermont's Expenditures. And with that, Charles, let's bring them up to the stage.
Good afternoon. My name is Annie Paumgarten, and I'm a healthcare statistical and data analyst for the state of Vermont. And today I'm going to give you a very brief project overview so that you have some context for Hiroko describing methods to bridge the data gap. Vermont's healthcare expenditure analysis genesis is in statute, and the goals are to estimate statewide health spending by broad sector and by major payer type. And the stakeholders for the analysis are very broad, but include the Joint Fiscal Office, who uses the analysis to educate legislators on the healthcare system, write policy briefs, and inform policy making when there are bills that are healthcare related. The state of Vermont decided to use standard definitions for this estimate and decided to use CMS's national health expenditures, state health expenditures, personal healthcare, broad sectors. And so I'm going to next describe some of the gaps in that analysis that led to our work with Onpoint. So I think the best way to introduce the sectors is to look at a dashboard I created with this public data set. Just going to load my dashboard here so that we can look at the national health expenditure, state analysis. Here, this first tab is a list of the definitions for those standardized broad sectors I had referenced earlier, including hospital care, physician and clinical services, other professional services. And I'll call your attention to two things. One, these definitions at the bottom there that say all except Medicare and Medicaid, and all except Medicare, Medicaid, and private. And those are definitions that I inserted into this dashboard because of data gaps. And there's also a link for information if you want more detail on methods, national health expenditure, state health expenditure methods and definitions. This first tab is aggregate spending, and there's a little toggle here if you want to look at your own state. But for Vermont, the top three sectors, hospital, physicians and clinics, and other health and residential and personal care account for about 2/3 of the total spending in Vermont under personal health care. And in the bottom graphs there, you can note under all except Medicare and Medicaid that the share of hospital spending has increased over time, and the share of physicians and clinical services has decreased over time as part of the total spend. Comparison percent of personal health care. This looks at the percent of the total spend of these sectors compared to regions and the US. And for Vermont, it looks like hospitals spend more, physicians and clinical, we spend less, other health and residential and personal care, we spend more, and prescription drugs, we spend less than regions and the US. And we can toggle here between the different payers. And for example, we can note that Medicaid spends less on hospital, the same on physicians and clinics, and significantly more on other health, residential, and personal care. Sector intensity, this is per person spending. If I toggle onto private, you can note that the sectors disappear, but we can see here that Vermont is 7th nationally on total per capita spending, and we can click among different sectors where hospital, we can see that Vermont is 4th. We go down to physicians and clinics, Vermont is 27th. So these differences are meaningful in terms of understanding our healthcare system. And then I have two other dashes quickly, growth trend. And if you click down to private, you'll note that that is only available for personal health care. And finally, comparison growth. This is the aggregate growth sectors across the years included here. And we can look by sector and other filters here. And you can look up your own state. And then lastly, there's a link to the NHE data. So that's a dashboard that hopefully creates some context for Hiroko's data gaps discussion following. And thank you.
Thank you, Annie. As she mentioned that NHA does not include the expenditure by the broad service sector for private insurance, which is a part of the state statutory requirements in Vermont healthcare expenditure analysis. We identified some opportunities to use Vermont APCD, Vermont All-Payer Claims Data, we call VCures from now on, to bridge the data gaps. The first gap was the service setting categorization in VCures claims data, which align with the NHEA service sectors. The crosswalk from a VCures data to NHEA service sectors was needed to complete the expenditure analysis for the privately insured payers. The second gap was the missing self-insured population due to the March 2016 Supreme Court decision in Govey versus Liberty Mutual Insurance. For the first gap, our crosswalk logic was built on claim type, type of bill, revenue codes, place of service, and provider taxonomy, using Medicare data in VCures based on the NHEA service sector descriptions. The chart shows the similar spending distribution by the NHEA service sector between VCures Medicare data and Medicare data from the state-specific report in NHEA. We applied this crosswalk logic to the private insurance data in VQs to estimate the expenditure by the service sector. For the second gap, we imputed the enrollment and the expenditure for the missing self-insured in VQs. Since Vermont VQs contains the historical data before and after the go-away decision, we were able to identify and analyze the self-insured ASO or ASW group names that dropped, as well as the group names that were retained after the go-away decision. The enrollment changes for the dropped group members were estimated using the medical expenditures paneled surveys run by the Agency for Healthcare Research and Quality. We estimated the annual growth factors from the major result of self-insured enrollees in the private sector. The per capita spending growth rates post-2015 for the dropped group members were estimated using the growth factors from NHEA Vermont specific data and VQs. In yellow bars, about 95,000 members were identified as the members of missing self-insured employer groups after March 2016. They represented 29% of the total private insurance population in VQs in 2015. The annual growth for the self-insured in private sector remained relatively flat over time in Vermont. The significant increase in overall self-insured population was explained by a large public employer group who changed their coverage plan from fully insured to self-insured. In 2018, about 40,000 members in Vermont Education Health Initiative changed their coverage to self-insured, and their data has been retained in VQs. In summary, we created a crosswalk from NHEA to VQs, which enabled us to analyze the service sector expenditures for Vermont privately insured population. We imputed the missing self-insured population and their estimated expenditure using VQs, MEPS, and NHEA data. At last, we would like to address potential limitations for other state APCDs, as not all state APCDs have historical data going back to 2015. Also, other states may not have retained as many self-insured plans as Vermont after the go-away. Thank you for listening to our presentation.
Terrific. Annie and Hiroko, thank you for sharing all of the good work that you're doing in Vermont. Before we kind of come, I have a couple of questions for you in follow-up, but just looking at the chat from many folks who are joining us today to start out the day. Karen Lee, I agree. Thank you to California's leadership, and I'm glad to hear Maine in January 2025 is going to start collecting rebate data at the NDC level. Please do share those requirements. Feel free to email me or Norm, and we'll get them out to participants. And then Jamie, please send us your question, and we'll get that to the right folks. But again, Annie and Hiroko, tremendous work, and thank you for sharing it with us. My first question is for you, Annie. What started all of this work? Why did you undertake it? And can you talk a little bit about how it fills really important gaps in our health information landscape?
So the Vermont expenditure analysis has been around for a long time, over 20 years. It's been in statute to complete this annual account for statewide health spending. And this iteration of it, the new part is that we decided to use the NHE standard categories and use our all-payer claims as the base to kind of build off of that with new sources. And really the primary use, I think it is broadly used by stakeholders, but the primary user is the legislature and the Joint Fiscal Office that uses this because it's broken down by service sector and also by payer, uses it to educate legislators and also understand the total landscape for any bills that come up or any policy briefs.
Really helpful. Hiroko, any other thoughts there, or like how this actually goes to address gaps that have been hounding you for years?
Yes. So yes, this piece of work that we've been providing is, one of the missing pieces in the NHEA, Vermont state reporting. For example, like we explained that the private insurance data does not have a detailed information. So, for the legislatures, it's important for them to look at expenditure by sector, to have a good insight into healthcare reform. So, this piece of work is very critical, groundwork for this expenditure analysis.
Yeah, and really helpful. And before I turn to talking about like data gaps and reporting limitations that folks should be aware of if they can undertake an exercise like this themselves, like did anything either in process or in results surprise any of you? Like, is there anything that you would want to kind of raise for others who might undertake a similar analysis?
I think for me, looking at the Medicaid spending and really having to go to that CMS 64 for those kind of special Medicaid investments that Vermont makes, that was one aspect that surprised me.
For sure. Hiroko, anything on your mind?
Yes. So in the NHEA reports private insurance as a total spending, and there's a big gap what we can collect in BQRs or other data source that we identify, and how to fill this gap, how to understand the gap. What is the source, what is missing. So it's isolating each element of the gaps. It's important, it's challenging, and then we try to accomplish in current work.
Terrific. So for folks viewing this from the outside, what should they know in particular about like the data gaps that you encountered or the reporting limitations? What should be like on their mind as if they decide to pursue something similar?
I think it's a lot of estimation can be drawn from APCD, but for example, like APCD does not collect stop loss or supplemental data, and or self-insured. But luckily, Vermont has a good retained self-insured data, so we can estimate what would be missing in the self-insured population. And there's lots of data source out there, and survey data, and then identify all the survey data that might fill in all this estimation of missing data, more for state-specific ones. Finding those will be important.
Good point.
Challenging, but I think it will help. It will help. Yeah.
Any closing thoughts on like how your experience in closing this really important data gap?
I would say that it took a little more time than I had anticipated, where, we all know we all exist in this complex world of healthcare, and we're always going down rabbit holes and exploring. And this particular exercise did, take that time and a lot of partnership with Onpoint to move it forward. So that's my last thought.
Terrific. Well, Annie and Hiroko, thank you for all the work that you do in the great state of Vermont. And I look forward to maybe bringing you back up on stage in a couple of minutes. But goodbye for now. So we heard from some of our friends in Vermont, and now we're going to move a little bit south to the fine Commonwealth of Massachusetts, where Molly Bailey, an associate manager at HCAI, the Center for Health Information Analysis, on their health informatics and reporting team, will be sharing her presentation on new data products to engage a broad audience, commercial prescription drug use and spending. And again, as part of the arc of this presentation, we started off hearing from Phil as he was just designing and taking methodical steps to establish a retail pharmaceutical claims dashboard. We saw from our friends in Vermont how you can take that data and start to present it and get in the hands of stakeholders. And I think we'll hear from Molly a little bit more about how this data can and could be used by any state's stakeholders to better inform our understanding of healthcare system performance. So with that, let's get Molly up here.
My name is Molly Bailey, and I'm a manager on the health informatics team here at the Center for Health Information and Analysis, aka HCAI in Massachusetts. In June, we published 2 products for our commercial prescription drug use and spending project, and today I'm going to walk you through that process and our findings. So for some background, every year HCAI publishes its annual report on the performance of the Massachusetts healthcare system, where HCAI is charged with calculating total healthcare expenditures, what we call THCE, which represents the total healthcare spending on an annual basis by Massachusetts residents. THCE includes spending from commercial, Medicare, and Mass Health, private and public payers, and other components like Veterans Administration healthcare spending and the net cost of private health insurance. We then are required to calculate THCE per capita and its growth rate to compare it against the healthcare cost growth benchmark that's set by the Health Policy Commission. Excluding 2020, where we saw unprecedented healthcare spending declines due to the COVID-19 pandemic, THCE per capita has exceeded the healthcare cost growth benchmark of 3.1% since the 2018 performance year. For the latest published performance period, 2022, THCE per capita increased 5.8%, well above the 3.1% benchmark and the second highest rate only behind the 2021 rebounding growth. We also examined different cuts of THCE to identify the drivers of overall healthcare spending. Shown here is THCE by service category, combining spending across the big 3 components: commercial, Mass Health, and Medicare. Here we see that in our most recent report, pharmacy spending gross of prescription drug rebates grew 8.8% from 2022 to 2023, growing to become the largest service category by total spending. Not shown, even when accounting for rebates on a net basis, we saw pharmacy spending increase 8.3%. This graphic from our annual report shows the aggregate change in service category spending from 2022 to 2023, showing that pharmacy spending, both gross and net of rebates, was the largest spending increase by service category, representing nearly 1/3 of overall THCE growth on a gross basis. Pharmacy spending gross of rebates increased over $1 billion, with net increasing $775 million. So in our most recent annual report and previous reports, we've identified that pharmacy spending was a major and consistent driver of growth in total healthcare spending. However, one limitation we run into is that the data in our annual report is submitted by payers on an aggregate spending basis, not allowing further insight into the underlying drivers of the increasing pharmacy spending. One quick note: prescription drug or pharmacy spending in this project means spending under the prescription drug benefit, known as retail pharmacy, and moving forward is only gross of prescription drug rebates. From a data perspective, the purpose of the commercial prescription drug use and spending project was to dig into the more granular therapeutic class and drug level findings to provide this missing insight into the underlying drivers of pharmacy spending and answer the big question we get every year: is the increase in prescription drug spending driven by utilization or by cost? Another note, we examined utilization as a market-wide number of prescriptions, and this analysis does not represent a per member utilization rate. Additionally, we wanted to engage a broader audience with more accessible data. The dashboard produced as the main data product of this project, as you'll see later in this presentation, takes a data dump nature, providing a wealth of data and data points, largely limiting our audience to existing data users and industry experts. So, to broaden our intended audience, we aim to produce a companion piece product that takes a step back and simplifies the findings in a more digestible story format. For this project, we used commercial insurance data from the Massachusetts all-payer claims database to identify high volume and high cost prescription drugs for calendar years 2018 to 2022 for fully insured Massachusetts residents. We then created two data products. First, the main one, an interactive Tableau dashboard and corresponding data set with the purpose of providing the data. This iteration was a refresh and a revamp of the previous commercial prescription drug publication interactive Tableau dashboard that focused on data from 2015 to 2017. The interactive Tableau presents spending and utilization metrics, such as number of prescriptions, average cost per prescription, total expenditures, cost per day supply, and cost sharing for many data cuts across therapeutic classes and drugs for 5 years of data. Secondly, we created a web page with animated graphics that takes a step back and walks through the story in the data, looking at big picture, is it cost or utilization? So first, looking at the data findings in the dashboard, we saw that the top 10 therapeutic classes of drugs accounted for over 90% of pharmacy expenditures each year. Immunosuppressants were the therapeutic class that accounted for the largest portion of spending, having high cost per prescriptions and lower volumes. Additionally, the top 3 drugs by spending across the 5-year period were all immunosuppressants: Humira, Stelara, and Enbrel. The most frequently prescribed drugs, with lower cost per prescriptions due to their generic status, were both cardiovascular agents. So here's some screenshots and examples of how the data is presented in the dashboard from just 2 of the 5 data views, allowing users to flip through the different measures, years, and therapeutic classes in some tabs, resulting in dozens of different views and a wealth of data points throughout the dashboard. So now, switching gears to our animated web page. Here's some findings we presented throughout this product. The big question: what was the overall driver of prescription drug spending increases from 2018 to 2022? Our data shows that it was average cost per prescription. Over the 5-year period, per member per month spending increased 45%, as the average cost per prescription increased 54%, compared to a 25% decline in the number of prescriptions. In short, overall pharmacy spending is increasing despite fewer prescriptions, leaving cost as the driver. Immunosuppressants, identified earlier as the top class in drug by spending, were consistently the largest driver of spending, with the increase in average cost per prescription outpacing the increase in number of prescriptions. And here's how the animated webpage presents those findings. You can see the data is presented in a much simpler way than in the dashboard, where we specifically outline the findings we want readers to take away. And finally, for our next steps, CHIA will be publishing its next annual report in March that will show the change in total healthcare expenditures from 2022 to 2023 and pharmacy's impact on those trends. We also intend to update the prescription drug dashboard with data through 2023 and onward moving forward, with the cadence to be determined and dependent on access to the data. For communication, a whole CHIA-wide goal is to assess methods of presenting new and updated reports to better serve or reach new target audiences. A lot of CHIA reporting can be pretty data heavy, so how can we better package or present this data to be more digestible based on the stakeholder? Thank you for your time, and please check out our reporting on our website and feel free to contact me with any questions using the email on the screen. Thank you.
Molly, really nicely done. Kind of stunning results, right? I mean, like, could you talk a little bit about what you took away, like, from the findings? And I was particularly struck by the 25% decrease in the number of prescriptions. Like, what do you attribute that to? And like, what market context should we be thinking about there?
Yeah, so I think it's important to keep in mind that this is just the commercial market. And I think over this 5-year period, we saw a pretty stark decline in the number of commercial members. So I think a lot of it can be attributed to that. I think additionally, the metric focuses on number of prescriptions and not so much day supply. I think there are additional analyses we could do with like the more granular metrics of like utilization per member, because we know that like drug utilization per member went up, but that didn't quite offset the decline in commercial membership, and how does the interplay of like a 30-day supply or the number of days supply interact with the number of prescriptions? So I think this was kind of a very like big picture take that we did, and I think there's like a lot of opportunity to dig into like those different forces of how the prescription drug market works.
Yeah. So you control the healthcare reporting agenda for Massachusetts. Like, what would you dig into next?
I think the dashboard offers like so much data and so many data points, and I think there are ways to take what we did with the more digestible format and explore areas of interest. I know behavioral health and sub drugs, or like insulin and the caps on that and what's going to happen with that, and then also weight loss drugs are a big topic right now. So I think there are different like special areas of interest that we can dig into while also still providing just the groundwork for all the data.
Yeah. And what's amazing when you have a resource like an all payer claims database, it allows you that like investigative flexibility, right? Depending upon where policy priorities turn. But like APCDs, I love them to death, but like they also have data limitations, right? Could you talk a little bit more about the limitations of analyses like this that others should be aware of as they're exploring it? You mentioned at the top, and we talked about in the last presentation or 2 presentations ago, rebates. Can you talk a little bit about the data limitations folks should be aware of?
Yeah, I think rebates was a big one for us because, in our annual report, as I showed in the first few slides, we do present both gross and net. So we collect rebates at a very aggregate level from payers, but we don't have it at the drug level or any usability really with it in the APCD. I think rebates is probably the biggest one that we came up upon while figuring out how to report, or should we try to take the aggregate percentages and apply, but we felt that wasn't really an accurate representation since they're really, really high level. So I think understanding how rebates plays into this level of reporting is possibly a next step, or definitely a big limitation.
Terrific. I'm going to take a couple of questions if you're game from the audience, starting with Patricia. She says, thank you, Molly. How are you able to estimate the difference between the price gross to net rebates? Was it an aggregate estimate, or did you have some data at a more granular level? Could you speak to that?
So in the commercial prescription drug use and spending project, which is like the main focus of this presentation, we're not able to we only reported everything on a gross basis. So rebates aren't accounted for at all. I think in our annual report, the very aggregate level reporting we collect rebates again at like a line of business of like commercial, Medicaid, Medicare. So
big number.
Very big number.
Yeah.
So we're able to apply it to those aggregate numbers, but we're not applying it to any of like the more granular numbers here.
Yeah, terrific. If you ruled the world, would you try to get down to a more granular level? Do you even think that's possible?
I know we've been trying to explore and expanding our rebate submission on the aggregate side. I think we run into a lot of pushback from payers that they don't have access to this information from their PBMs. Some payers tell us that they can, only get this information at an aggregate level. I'm not entirely sure so much on the APCD side of things. I deal mostly with the aggregate submissions, but I know like data access from the data submitters, even just because of the complexities of the prescription drug supply chain can sometimes be an issue too. Yeah,
and folks can, I'm assuming, can certainly reach out to you if they have other questions offline. I have one clarifying question and one final question from the audience. Then we're just going to bring everyone up. The virtual room is going to get very crowded. We have a question from Sarah. She has a question about PBMs. Does commercial here also include PBMs for Medicare and Medicaid, or are those still included?
Those are excluded. We're only looking at commercial claims data.
Okay. And then from our friend Nate, have you identified specific drug products where costs and prices are disproportionately driving spending trends relative to utilization?
Yeah, so I think in the dashboard itself, there's just so many data points that we weren't able to like pick out specific drugs. I think if you take a look at the interactive piece, we do dive deeper into immunosuppressants, and then like one of the immunosuppressant drugs where price is exceeding utilization, or utilization is exceeding price. But I think just because like you said, the APCD is just a wealth of information, that it was almost like a little bit too much to pick out specific drug products beyond what we did in the interactive piece.
Terrific. Well, Molly, thank you so much for your presentation and closing us up on our set of presentations today. I'd love to bring all of the panelists back up, and I have a couple of just general questions for the full team here. Folks in the audience, please do raise your hand with some and put some questions in the chat, and we'll try to get to them. Charles, please like put them in our group chat. For easy viewing for me. But one question to start for you all is, we have some very cool dashboards being developed, California and Vermont and Massachusetts. How do you make a dashboard that's going to be useful, that's actually going to provide folks information that they can then take and use? So if you'd want to take that first question, please raise or come off mute, and I'll give it to you to take the ball. I'm going to wait here awkwardly until someone volunteers.
Yeah, I can go. I think one thing we did, so the product that we published this year was largely a refresh from previous years. And I think there were some instances where we had to pare down the amount of information we were showing, because it was overwhelming. We were showing, drug, like 5 years of drug trends and spent like all these different metrics. So I think like it's very important to provide all the information, but I think visually it has to be digestible in some way. So I think a lot of the times we'll also pair it with, like, we'll publish the data set, the underlying data set that we use. We'll publish other products that are more useful for people that want to dive deeper into the data points that are on the dashboard.
Terrific. Anyone else have anything else in that one? Otherwise, I'm going to move on to another. So all of you are producing really useful information that give us deep insights into one part of our healthcare system. Your organizations, your state health data organizations writ large, can then take that information and start to tell a story about how the healthcare system is performing. Could any of you speak a little bit to how the information that you are preparing to present or presenting will be used by your larger organization to, again, present that overall picture? What gap does it fill in the overall reporting? Annie, I'm gonna call on you, because like it's a big gap, and it's one that's near and dear to my heart.
I think in terms of, well, I guess to answer, can you repeat the question? Sorry.
Yeah. So like the work that you're doing, it fills a really big information gap in how we understand like the self-insured part of the market. Why is that important for the Green Mountain Care Board, and why should that be important for policymakers to have that gap filled for the work that you're doing to be valued?
Yeah, I mean, I think it's incredibly important for all of our work, for our healthcare reform work, just to understand the total landscape. I think, as a group, I got some stakeholders together and I said, what do you really need to know? And we came up with collectively 4 measures to look at aggregate, to look at percent of total spend. Like the percent of the hospital spend in Vermont is growing over time. And that looks different than other states, right? And the per capita, and then the percent growth over time. So like we focused on those 4 measures because that's what people really, wanted to know from the stakeholders as we were planning. So.
Terrific. And I have a question, and this might be a little bit for Phil and Molly from the audience. Jamie, I work on very similar dashboards. How many drugs were excluded from the top 25 after taking out drugs with less than 100 users? There are some extraordinarily high-cost drugs out there. How do you set that threshold, and what's the impact it has on which drugs you profile?
I'll field that first, if you don't mind. Great question. So first of all, it really only affected the last one, which is the median monthly, right? Out-of-pocket cost, because, right, as you can imagine, top 25 most frequently prescribed or most costliest, they're not going to have under 100 users in California, right? It was just primarily the median out-of-pocket cost one that eliminated And once again, I would say in that case, out of those 25, it probably eliminated 6 NDCs from that list. So that 6 of them were removed, and then obviously it was backfilled from there. So that's the only part of the dashboard that was really dramatically or partially affected.
Really helpful.
And making that decision is partially based on the idea that, right, these dashboards are for California, right? And if you have a drug that only is affecting 100 users, that is important, but it's not necessarily the bigger picture that we wanted to focus on at this point, right? In the future, we could explore like specialty drugs or et cetera that could drill into more smaller units, smaller people, affecting smaller groups of people.
Molly, do you have something to add?
Yeah, I think similar to Phil's point, I think our threshold was 11 prescriptions because we weren't exactly looking at users. We were looking more at prescriptions. So I think the threshold was 11 and it maybe dropped like the tiny, like 2, 3, 4 from any of our tables. So it wasn't a huge impact, and we definitely don't feel like it affected the results just because of what Phil said. It's a very small number of prescriptions.
Really helpful and good question from the audience. I'm actually going to go to a full round robin here before we close. I would love to know from you, for my own selfish purposes, but I'm sure it'll be shared by many in the audience. If I was to approach an analysis like yours, if I'm trying to use that data to understand value in our healthcare system, what words of advice would you have for me? And I'm going to start with Hiroko, and then I'm going to go to Annie, Molly, and Phil. Words of advice for undertaking an analysis like yours.
I see healthcare spending is maybe 1,000 pieces, but try to make it 500 pieces and start simple, and then we can challenge 1,000 pieces.
Good words of advice.
I don't know if this is advice, but that's how I feel.
Yeah. Annie, how do you feel? I feel very anxious, but I mean, how do you feel about this?
I think to focus on actionability, to start with stakeholders and really like focus a lot on, what is the value to stakeholders? How are they going to use it? And to start there and then design the methods based on that.
Start with the user. Good advice too. Molly.
Yeah, I think, in the realm of the prescription drug product, I think it's interesting to see new therapies and such emerge, like the COVID-19 vaccine. And it's hard to put, the value of that over just like total expenditure. So I think exploring these new therapies and what they add is tough in the context of their total spending, but definitely worthwhile.
Phil, close us up.
Rely on your SMEs to identify blind spots. So I go to my SMEs early and often, and I'll just show them high-level numbers, middle-level numbers, low-level numbers, take a temperature.
And thinking about them probably early on, like who are you going to engage through the process, right?
Yeah.
Really good advice. And thank you all for your tremendous presentations today. I learned a lot by working with each of you to get to today and through the conversation today. And I know that many in the audience probably did too. Charles, if we could take folks off of stage, I just have a couple of closing thoughts. As Phil said, like engaging SMEs, like connecting folks who are neck deep in actually making sure that we get complete and accurate data to those who really understand the information needs working in our landscape is the secret sauce. It's what makes health data organizations across the country so important. And I think we saw that through our conversation today. California building from the ground up with those use cases in mind. Vermont really helping to fill information gaps to help inform our policymakers of a critical part of the market where people are getting insurance at sometimes often for the majority of employer-sponsored insurance with the self-insured. and then in Massachusetts. Again, continuing to build off of a long track record of collecting this information to make it more and more actionable. And one closing thought to Phil's point about engaging SMEs early, I would look at all of those who are part of this conference as also part of your SME community. One of the most wonderful things I've loved about being part of the NAHDO community for the past decade is that down to an instance, every time I pick up the phone to call someone to ask a question, ask for advice, there is always a pickup on the other side. Thank you to NAHDO for having me and for having us. Thank you for all of you for being NAHDO members and for joining us. Thank you to our sponsors today. And also thank you to Norm and Charles for allowing us to have such a smooth event. Thank you for having me, and I look forward to chatting more.